Welcome back. Scaling up technologies for early detection of Alzheimer's pathology and cognitive impairment promises to transform the global response to Alzheimer's disease. Digital biomarkers and fluid biomarkers to detect the disease are advancing rapidly in clinical practice and will enable a more simple, timely, and accurate Alzheimer's diagnosis. What do these tools and technologies mean for patients and their doctors? Here to lead that conversation is Drew Hoseful, Executive Director of the Global CEO Initiative on Alzheimer's disease.
Good afternoon, everybody. It's great to be here, and I'm honored to be joined by three experts who will discuss how advances in new tools for detection of cognitive impairment and diagnosis of Alzheimer's are changing how people living with Alzheimer's disease or at risk for developing it are being treated and cared for. As George shared in his opening remarks, it's an exciting time in the field, and the work that these three experts are leading are some of the reasons why we should be excited. These experts include Tom Fagan, Vice President of Eisai. Eisai is a large global pharmaceutical company that has led innovation in Alzheimer's treatment and care for decades. Also joining me is Dustin Hammers, Associate Professor, Department of Neurology, Indiana University School of Medicine, and a board-certified clinical neuropsychologist. Dustin also participated in a pilot program funded by the Davos Alzheimer's Collaborative, looking at how new tools can improve patient flow. And finally, Suzanne Schindler. Suzanne Schindler is Associate Professor of Neurology, Washington University School of Medicine. She's also a clinical neurologist. Suzanne co-chaired a CEOI work group that developed recommendations for how blood-based biomarkers should be used in everyday clinical practice. So to start this discussion, let me just throw a question out to you, Tom, if you don't mind. Congratulations to Eisai and on the launch of lecanemab, or Leqembi as it's called commercially. I'm hoping you can tell the audience what's unique about lecanemab and how its introduction changes how a person living with Alzheimer's or experiencing symptoms of Alzheimer's is now treated.
Well, Drew, thank you very much for the question and the opportunity, first and foremost, to join your session. Dustin, Suzanne, I'm honored to share this time with you as well, and looking forward to the conversation. Grateful to be here as a representative of Eisai in this very exciting time in the field, as you indicate and set up very well, Drew. Leqembi, as we have branded our product lecanemab, is the most recent contribution from Eisai. Again, as you indicated, this organization has a 4 decades long continuous commitment to exploring scientific and medical contributions to help patients and families with this disease live better lives. And again, our gratitude to be present in the field and to have been present so long, fighting this fight is just very, very special for us. So Leqembi, a couple of things about Leqembi that I think are important, and you asked for considerations on what makes it unique. I think as the field has moved towards directly engaging the disease and the underlying process of the amyloid cascade and the biomarker of plaque, we always must remember the chronic insidious nature of this disease. And Leqembi works. I think it's important to consider how it works. It does a few different things. Importantly, it binds with the highest degree of affinity as a compound to the protofibril stage of the amyloid cascade. We believe, and there's literature to support, that's a toxic component of this overall process. And Leqembi also engages to remove the accumulated amyloid plaque, which has been demonstrated in results that supported our accelerated approval and repeated as a secondary endpoint that contributed to our traditional approval. So we're again pleased to make this contribution and think those are important considerations. And then further, we have the privilege of now having a full traditional approval from the FDA. That approval is based on again years and years of research, but most recently the results from our Clarity AD clinical trial that were first press released last September, of course, presented at CTAD now almost a year ago. And in that clinical trial, Leqembi demonstrated both statistically significant and clinically meaningful impacts on our primary outcome, which is CDR sum of boxes, and key secondary outcomes that included ADAS-Cog, 14 IADLs, and again, clearance of beta amyloid neuritic plaque, all pointing to the opportunity we now have in the field to engage and slow the progression of this disease. These components and this prospect of slowing the disease does contribute hope to people and families and to practitioners. We're very grateful for the interactions we have, and there's a general sense of optimism in the field right now. We'll talk about later in this panel, of course, about what it takes to identify the appropriate patients and treat them, but a general sense of optimism about this opportunity to engage the disease and slow it down. Very, very important that I balance some of this consideration. I think as we move forward in a field, we're all aware. Of course, we know safety is a critical consideration, and with monoclonal antibodies that are directed against aggregated forms of beta amyloid, including Leqembi, can cause the side effect that is referred to as ARIA, or amyloid-related imaging abnormalities, whether it is swelling or potentially bleeding in the brain. The incidence and timing of ARIA events can vary among the treatments, but there are a number of considerations for physicians and patients as part of a benefit risk consideration for a product like this. Still, we are just thrilled for the opportunity to begin introducing this into clinical practice.
Yeah, that's great. Thank you, Tom. So many important points, and the idea that Leqembi can slow the progression, I think that's really important. I also liked what you just said was, you're in this, you're fighting the fight. And so, I'd like to go to Dustin, who's fighting the fight with us. Dustin, you're a neuropsychologist. I think it would be really interesting, one, just to make sure we all know what a neuropsychologist does. And then two, we're talking about how there are new tools for setting up the diagnostic funnel. So what's your job? How are you fighting this fight? And how are these new tools helping you do your job?
Certainly, and as Dr. Fagan mentioned already, just greatly appreciative to be part of the conversation today. I think conversations and discussions like this are really helping move an exciting time forward, and honored to be on the call with the panelists. And so a neuropsychologist, I tend to describe to my patients as, that's a 50-cent word, at least maybe 75-cent word. And it's a psychologist who focuses on memory and thinking changes. And so when working with patients, my specialty works hand in hand with neurologists or other experts who are in the process of evaluating for, diagnosing, and then treating Alzheimer's disease specifically. And so we know from research and from experience that people don't always have the greatest sense of their thinking abilities. And so some people have a really good intuition about changes that may be occurring. Other folks may not have a good of a sense. And so coming in for a cognitive evaluation through neuropsychology, we actually will be able to apply comparisons to folks their same age and education, which is a really important piece because we often, we know that people have changes in thinking skills as they get older. It's part of the normal process, the normal aging process. And so we're able to control for that and be able to understand that a little bit better. And so while a lot of the measures that we give in a traditional 4-hour cognitive assessment are still rather paper and pencil based, still in person, we're seeing a big incorporation of digital formats to be able to, particularly in the early screening phase of a pipeline, Drew, as you alluded to. And so I can talk a little bit more later on about some of the things we've been doing at IU. But one of the details is that we have been working through the Davos Alzheimer's Collaborative, specifically on a project looking at a particular digital cognitive assessment tool, which is from Linus Health. We're calling it just the DCA is what we're abbreviating it. And that has been very influential in being able to improve access to these type of baseline evaluations, screening evaluations, essentially, to be able to get an understanding of where people are and get them into the entire pipeline.
And so the way it improves access to these tests is because the digital piece means that it's offered on a platform that's better, or I guess quicker and cheaper. Is that the quick takeaway?
There's that piece, because you're absolutely right. It is packaged in a way that can be administered efficiently and relatively cost effectively. But then additionally, neuropsychology, I'm biased, I think there's a lot of benefits, but one of the cons is you need to have an expert to administer the different cognitive tests to make sure that they're standardized and done in the proper fashion. And so a real key to some of the digital assessments are the fact that by giving this over a tablet, for example, the instructions are already pre-programmed, and there really is not much of an involvement that a doctor's office needs to have other than handing the tablet to the participant or the patient coming in and making sure that there's no distractions and things along those lines. And so it greatly improves access to some of these screening tools in clinics where previously they wouldn't have had a specially trained administrator.
Yeah, that's fantastic. Thank you. Great explanation. So, Suzanne, I want to bring you into this conversation. So, given your role at WashU, you coordinate biomarker testing at what really is a cutting-edge dementia specialty clinic. And you've been doing this for a while. What's changed in how your patients are being diagnosed today versus, say, 3 to 5 years ago?
So the biggest change is that we're doing biomarker testing much more frequently than we were in the past. So about 3 years ago, we were doing maybe 5 biomarker testing or testing 5 biomarker patients per month. So not very frequently. And now we're up to almost 50. So we've gone up about tenfold in terms of the number of patients that we're testing for biomarkers. And we're also using different types of biomarkers. So we're testing about a third of our patients with blood-based biomarkers. None of those tests were available even 3 years ago. So this is really a big change. We do sometimes use amyloid PET, although not very frequently, just because it hasn't been reimbursed by insurance and Medicare, although that may change. But we do expect that our volume of biomarker testing will continue to go up. And a major reason for this was that in the past, patients asked, so if I do the test and it's positive for Alzheimer's disease, is there anything you're going to do different? And the answer was usually no, that we would still manage them the same way. But now that we have lecanemab and likely more drugs will be approved in the not too distant future, there is something that we might do different. And so having an accurate diagnosis becomes much more important. And another way that things have changed is we're doing this biomarker testing much earlier. So in the past, we would, when people came in with very subtle memory and thinking changes, we would do our typical assessment, and then we do what we call watchful waiting or cognitive monitoring for maybe 6 months to a year. And then if they continue to decline and we were worried about Alzheimer's disease, sometimes we would do biomarker testing. But now that there are treatments available, we know these treatments are likely to be most effective the earlier they're given, we're being much more aggressive. And so at their first appointment, we're now setting people up for biomarker testing. And so we're testing more often, we're testing earlier. And really this is largely because of these disease-modifying treatments. So things have really have changed in terms of the way that we're thinking about diagnosis.
Yeah. So from watchful waiting to early action, that's really interesting. So I imagine if something's being increased in use, like a blood-based biomarker, is there something that you're using less of now? Is there anything you're doing less of as a result?
Uh, no, we're really doing more of everything. So
Okay.
again, we were testing about 5 patients per month a few years ago, and now we're doing close to 50. So we're mostly doing CSF testing, but we're still doing some amyloid PET now and then, and we've added on these blood tests. So no, nothing has really decreased. We've really
Okay.
increased everything. And we've also been increasing our number of providers to try to increase our capacity to see patients.
And I want to come back to that about how healthcare systems are scaling to meet the demand from patients. But Dustin, you mentioned Linus. Tom, you mentioned Leqembi, and I think a good example of a blood-based biomarker is C2N. These are new tools, right? They're out there, they're available. But I just want to open it up to all three of you to talk about if there are any barriers to using these new tools.
I can talk briefly about that. So in terms of the blood-based biomarkers, there's obviously a lot of advantages to using them. Patients would much rather have a blood test than a spinal tap. But right now, payers aren't routinely reimbursing for the cost of blood-based biomarker tests. So even though some of these tests have generous sliding scales for people that are kind of in the donut hole, they seem out of reach financially to pay for the tests themselves. And the other issue is that we're often doing this biomarker testing to see if someone's eligible for Leqembi. And we're not sure if payers will accept blood-based biomarkers as evidence of amyloid positivity. We haven't tested this yet. We know they'll take CSF biomarkers and amyloid PET. We're not sure if they'll take blood-based biomarkers. So that's a reason for us to wonder if it's okay to use the blood-based biomarkers, or if we should just do CSF on those patients. So those are significant barriers. I think that those will be addressed when more data is released, and hopefully some of these blood-based biomarkers get FDA approval.
Yeah. I mean, listen, the fight that needs to be fought to ensure that there's access, something I know Us Against Alzheimer's cares deeply about and spends a lot of time on. Any other, Tom, Dustin, before we move to the next question, any other barriers to highlight on access to these new innovations?
I'm happy to jump in unless you, Dr. Hammers, have any commentary.
You can go first.
Okay, well, thank you. And Drew, thanks for the question. And I just think it's important to recognize, in all seriousness, I'm joined by esteemed colleagues here with Drs. Hammer and Schindler, both as individual practitioners and then the places within which they work. They are forward thinking and as much out in front of this transition into clinical care as arguably anybody in the country and in the world. And so I think one of the just practical barriers we have to remember that not everybody is as closely connected to the innovation that has occurred in this field over the past couple of decades, and of course more recently, for example, that leads to the opportunity of a product like Leqembi. So another barrier is just awareness, good fundamental information about what constitutes a good comprehensive clinical evaluation, especially to accurately identify patients and hopefully earlier in the progression. I failed to mention in my opening commentary to you, of course, Leqembi is indicated in this early AD space. It should be initiated in patients with either MCI due to AD or mild Alzheimer's dementia. And there is a change in clinical practice broadly that we'll all need to go through to ensure that the physician community broadly is comfortable and confident at using these tools earlier, so that the most appropriate patients for this therapy or others are identified, treated, and monitored. So just don't want to take anything for granted amidst the optimism and the contributions, again, of physicians like Drs. Hammer and Schindler. We have other work to do to support physicians broadly, but the optimism is high. We encounter, so many people, of course, want to do more to help patients and their families with this disease. And it's wonderful work, but it's work that needs to be done.
Yeah, great. Dustin, over to you.
Yeah, in terms of access, I don't mean to keep repeating the phrase we're in an exciting time, but we all agree on this call about the exciting time we are currently living in, both with the results and the FDA approval of lecanemab, but additionally the enhancement of and development of some of both the plasma biomarkers and the improvements in digital cognitive assessments. And so the timing of this is really nice in terms of we are starting to have tools to treat, and we have tools to improve assessment and access. One of those things that we need to always be considerate to ensure, though, as Dr. Fagan alluded to, is that our core line of who are going to be identifying folks with cognitive difficulties, that they are prepared in order to do so. At the project that we're working on with IU, Indiana University, and IU Health in conjunction with the Davos project is a rollout of digital cognitive assessments in primary care. And so we've had the luxury of working very closely with some of our colleagues in primary care, because the reality is these tools are really helpful. We can screen a lot of folks, which means instead of waiting until specialty clinics, we are able to reach out in primary care clinics. But that puts a lot of burden on our colleagues in primary care. And so a lot of the emphasis of what we've been doing so far with this project is making sure that our primary care providers are having their needs met as well as their patients who are becoming our patients, to make sure there are no gaps in the process. And the other piece along with that education is it is truly, as a psychologist, kind of aware of this, but see it every day, the way an ask is delivered can greatly influence the acceptance of that ask. And so having an entire primary care team on board with an implementation of a digital cognitive assessment or something along those lines, patients are really sensitive to looking up to their primary care providers about, is this something I should do or not? And ensuring that the primary care providers have full confidence in what they're doing and have been given the tools to do so as they're starting to enter into the dementia realm, I think is going to be a major piece of importance moving forward.
Yeah, fantastic. I've been in this Alzheimer's space for 17 years, and there's been a lot of disappointment. So, Dustin, being excited is okay. But Suzanne, it's great to hear Dustin kind of start to lay out how Indiana University health system is responding to the change in the environment. Yeah, I want to kind of put the same question to you, and just what's Wash U doing to better deliver new treatments and care?
Sure. Well, we've only had these new treatments for a couple months. And so we've really been working hard to start to deliver this drug to our patients. And we've been planning for this for a while. We expected that lecanemab would be approved, but it's still been a difficult transition. Anytime you try to do something new, it takes some work. But getting someone on lecanemab is a pretty complex multi-step process. And it's kind of started off with each clinician in our group leading our patients through each step of the process, which has been informative for us, but not very efficient. And it's taken a lot of time from clinicians. And we have always planned to have a specific lecanemab clinic, and that's now been, I think we're on our third clinic now, but we're going to increasingly be shunting patients this clinic where they can go through all these steps with a nurse practitioner and then follow it in that clinic. And we're actually trying to hire another nurse practitioner to help with that. And we've been, actively recruiting a number of people. Our provider group has gone from 12 to 16 just in the last couple of years, and we're adding more folks. And these are individuals who will mostly be seeing patients. So we're doing what we can to increase our capacity. We expect that most lecanemab is going to be provided in a specialty memory clinic sort of setting. And actually some providers in our community who started patients on lecanemab before we did have then transferred them to us, which has been kind of interesting.
Yeah.
But we do need to figure out a way to, as Dr. Hammers was talking about, shunt people from primary care more efficiently to specialty care. Because there just aren't enough dementia specialists to take care of all the patients who could benefit from this treatment. So we're starting kind of at the beginning with the most specialized environment, but we need to figure out a way to educate a lot more clinicians and providers about how to screen for dementia and how to select patients who are good candidates for lecanemab. So there's a lot of work that needs to be done, especially on the educational front.
Thank you, Suzanne. Tom, I want to come to you here. The Leqembi clinics, that's really interesting. Is this common? Are you seeing these? Are these popping up at every corner? What's your kind of national view of how the healthcare system's responding to offering this treatment?
Well, I don't think I can say, even if I would like to, that it's necessarily common yet, or that we've achieved any kind of a scale. There's, as I indicated before, and I'll reference Dr. Hammers as well, there's excitement, there's optimism, and there's variability about how different physicians in different care settings are, setting themselves about, going through this process, very formally in order to identify appropriate patients for treatment with Leqembi. We've talked here about two, top tier medical centers, within this country. And many others are also embarking on this journey, but again, each in their honestly own way, sorting out just how exactly this is going to work within their systems and identifying oftentimes, certain physicians who will initiate, this work within a system, and they will, carry through a number of patient experiences so that they can learn about how it will work for them: order sets, protocols, checklists, documentation, EMR, incorporation, and otherwise. But it's not only limited to top medical centers. As we've discussed here, there's a lot of great work going on in community setting as well, where, I should acknowledge, they encounter many of the same challenges, that we talked about here, whether it's just a relatively small number of neurologists compared to the potential relevant patient population for this, staging the disease earlier, the dynamics between primary care and specialty centers, and the role of each physician type. These are all things that are getting sorted out in both places, but there's a lot of wonderful activity in the community setting as well. They have to do some work in order to align themselves, whether it's to imaging centers for PET amyloid imaging, or establish the means by which they will draw CSF and have it analyzed and assessed, and then certainly also consider infusion and MRI monitoring capabilities. So it's a lot to put together, for sure. And the setting is important, but I think right now, and as Dr. Schindler indicated, predominantly there's a specialty orientation to this. We use neurologists as the easiest example, and probably the most prominent. And while the setting is important, I think right now what's also important is just this spirit, this willingness to dig in, engage, the enthusiasm, the readiness for this. Many acknowledge, the change that is required to appropriately identify, treat, and monitor patients. And then within that group, there's just a collection who are more eager to help create some of these initial experiences and then share those experiences. So again, we remain encouraged. It's hard to draw any kind of blanket commentary right now, but there's utilization of this product all over the country in many different types of settings.
Great. Suzanne, I want to ask you a question, because we're talking about blood-based biomarkers a fair amount here, but we've also seen some direct-to-consumer blood testing that was launched recently, and I'm thinking specifically of Quest. And so I just want to hear your thoughts on, is this Quest test different than the blood-based biomarkers that we're talking about?
Sure. So there are quite a few blood tests that are under development right now. There's not just one. There's actually 16 or more tests that are either in development or in use clinically right now. None of them are FDA approved. Some are much better than others. So some perform, we think, very similarly to CSF biomarkers, and some are not much better than a coin flip. So that's a pretty wide range of performance. And a lot of people don't know which tests are good and which tests are bad. At WashU, we have developed some of these tests, and so we know a lot about some of them. And so we're only using the test that we think is the best performing. The Quest test is not that. So the Quest test was actually modeled after a WashU test, but it has very little validation data, and its performance in that the little bit of data that's available is not very good. So that's one issue. And then the second issue is that they are offering it directly to consumers. Now they do say that they have a physician call the patient if the patient is positive. I don't know exactly what that exchange is like. But it's overall concerning to me for a couple reasons. One is, I return a lot of biomarker results to patients, and I know that this is typically a pretty intense conversation about what this means and can take an extended period. And that's when I'm using really high accuracy tests. So I'm not exactly sure what that exchange would look like with the Quest test. And then they're also offering it to individuals who have essentially are asymptomatic, have minimal cognitive symptoms, and in some cases are younger, so are at very low risk of having Alzheimer's disease pathology. And just based on some calculations, they would be expected to have a very high rate of false positives. And that's concerning to me because getting a diagnosis of Alzheimer's disease is a pretty life-altering event, and it's concerning to me that half the people who will be getting this diagnosis is probably not correct. And they are saying that it's not to be used as a diagnostic test, but it's not totally clear to me that a patient would not interpret it in that way. I think when you have a test done by a diagnostics company, and it talks about risk for Alzheimer's disease. If it's positive, a lot of people will think they have Alzheimer's disease. So there are lots of things about this that are problematic, and I know that the FDA is concerned about this, so much so that they're now changing. This is not just about Alzheimer's disease tests, but other types of tests as well. But the FDA is now considering some rule changes or planning some rule changes in how these tests are regulated. So I would not recommend undergoing any type of Alzheimer's disease test without a thorough evaluation and a clinician to integrate the results of that test with the rest of your clinical workup. There's a substantial kind of harm that could come from direct-to-consumer tests like this.
So not to put too fine of a point on it, but if I'm thinking about going to get a test like this Quest test, what should I do instead? What's your recommendation?
So if you're concerned about memory and thinking problems, I would go see your primary care doc or ask for a referral to a neurologist, and they're much more likely to be able to address your issues.
Okay. Very practical. Thank you very much. Dustin, I just want to go back to you here because we talked about with Suzanne and Tom, and you alluded to a little bit of it at Indiana University about this Leqembi clinic. But could you just elaborate on what Indiana University Health System is doing here?
Certainly, a lot of similarities to WashU and what Dr. Schindler was describing. We're all kind of had been in various levels of preparation, and then FDA approval occurred, and we need to put this into action. And so I actually have to give a lot of credit to our colleagues on the neurology side who were able to put together this clinic in such a quick fashion. And so one of the keys, and so we've been able to have at this point, we've been going for 4 or 5 weeks, I believe, of folks coming in for their every other week appointments for the infusions. And during that time, we've learned a lot about, number one, space issues and about a flow of patients through in the pipeline. And one of the biggest keys that we've noticed so far is the importance of having what we're terming a brain health navigator, or just a health navigator, going through this process. Because at the moment we are working with patients who we may have flagged from our specialty clinic for several months, because this has been in the ramp up process. But as we move along down the line, a year or 2 years from now, individuals who are going to be identified potentially in primary care will be making their whole way through working with specialty clinics and then getting the lecanemab drug itself. And there's a lot of potential for patients to fall through the cracks. Our clinical care providers are doing an incredible job with all of the different aspects of care that they are providing for their patients, with which cognition is now an additional one, given the potential for treatments with lecanemab. And so, but even given that, we are knowing that there's a lot of hurdles for the providers. There's a lot of hurdles for the patients themselves in this type of clinic. And so having this navigator to help them through this process, we're finding to be very important moving forward.
Yeah, I mean, it's just a great innovation, and having navigation through a healthcare system makes a lot of sense, and we've seen this model in oncology too, and we know that the output means that from detection to resolution is faster, and so we're talking about speed here and the importance of speed. So I really think that's absolutely amazing. So I just wanted Dustin and Suzanne, you guys are on the front line. So Suzanne, you mentioned kind of how you talk to patients, but I just want to go back to that. And when you are talking about these new tools and these new treatments to patients, what are you hearing? And if either of you want to react, I'll pause here. Common questions, concerns.
So I think that especially related to lecanemab, that patients are excited that they have, there's a sense of hope. I think because it's so new, there's a lot of questions. Before I order it, we typically have a conversation that lasts about 30 minutes to 45 minutes, going over risks and benefits. And no, it's not going to make you better. It's going to slow things down. But yeah, I think people are excited about it. That they realize that if they had developed symptoms a few years earlier, that this would not have been a possibility for them. So, and then with respect to blood tests, I think that patients are always much more excited about blood tests than a spinal tap. So, I think that they're thankful when that's a real option for them.
Dustin, anything to add on what you're hearing from your patients?
Yeah, we're getting a lot of questions. Yeah, I'll steer more towards using some of the digital cognitive assessments, and particularly in primary care. Getting a lot of questions about the validity of these type of tools. Can I do this computer game is this really gonna tell me how my thinking skills are? And in particular, if they end up having some difficulty and they didn't think they had any difficulty coming into it, are you sure this is right? That type of thing. And so we're absolutely in the process right now in terms of the digital assessment forefront of ensuring that tools are properly validated. Some tools out there have been around long enough that they've developed some good validation, research, and evidence behind them. Others are still in that process. And so what we like to talk about, particularly in the study with the IU Health, IU Linus, is that the the validation tools, the comparisons that we've been making so far, that we've been examining so far, they are very strongly suggestive of some good validity there. But we're continuing to look into that because we don't want to give patients the wrong information, first of all. And so that is a big back and forth that we're having with patients currently. And additionally, we're also talking about individuals who are experiencing difficulty at a certain age in life. And there are individuals who are elderly. I think if we're making general statements, there's less acceptance of computer incorporation of everyday life in that generation than our children's age, for example, just as far as an extreme. And so trying to ensure that this movement that we're making in the medical system towards increased computerization and digitization is accepted by our patients and trusted, I think is a real factor that we get to focus on moving forward as well.
Yeah, excellent. So I'm watching our time here. I just want to end, with one question the same question to all three of you. So, we started by talking about this exciting era. Tom, you discussed Leqembi. Dustin, you talked about digital tools that can be scaled to meet the need, and Suzanne, you talked about blood-based biomarkers. And by this time next year, we're hopefully talking about another FDA-approved treatment, which is donanemab from Eli Lilly. So exciting, yes, but we're advocates, and so there's excitement, but. And so the caveat here is that, as we've discussed, the pace of implementing these new treatments and tools is slower than anybody would want. So you're talking to an audience of advocates, powerful people who can make change. What's your one piece of advice what's the one thing you would say to these advocates to encourage them to do to pick up the pace of this progress? I'll start with Tom and then go Dustin and Suzanne for the final word. Tom, to you.
Well, I certainly appreciate that. I would have been happy to go last and let the doctors make their commentary. But, I have the privilege right now of traveling really all across the country and interacting with physicians in different settings and different levels of understanding of what is happening now, in the field, again, in terms of these tools to support evaluation, and diagnosis, and then certainly treatment opportunities for a product like Leqembi. And I recently had an interaction it was very touching. It was meaningful, and it was just so very positive. It was a 30+ year neurologist indicating that he has never enjoyed his career or profession as much as right now, in the midst of all of this change and this first step of an opportunity. And it's encouraging because we do encounter, Dr. Schindler, customers who are working through some of the challenges that you very clearly elucidated during this conversation. I want to encourage people to believe they can. That there is information out there. I've worked in this therapeutic area now for more than 10 years, and never encountered anybody who didn't deep down want to be able to do more to help people and their families who are either at risk for or beginning to encounter or fully embedded in this disease category. And now, it's a great step into a new opportunity in clinical practice. So believe you can. Information is out there, whether it's from ASI or otherwise, and take that step in this next phase of our collective effort to defeat the disease.
That's great. Believe and push is kind of what I hear, Tom. Dustin, 30 seconds, Suzanne, 30 seconds, and then we'll wrap it up. Dustin.
Yeah, in thinking about the pace of progress, there needs to be some curbs to pace, just to ensure patient safety, of course. And what I like to think about is that while some of these processes will take time, we now have a disease-modifying treatment. And once you have one, the pace of improvement will speed up as a result. And so we have a comparator that everything else needs to match. And I think that will inherently improve the entire process.
Suzanne, final word.
So Tom was talking about how everybody is approaching lecanemab in a different way, in their own way. I think that's true to some extent with biomarkers as well. So really, we're doing a big experiment with lots of different conditions. And I think what we should do is look at how people are doing. Like, who are the people that are getting patients through this process safely in large numbers, and how are they doing it? And then we bring that model to everybody else. I think that's how we speed things up.
Thank you so much. Excellent. Really appreciate your expertise and your willingness to join us here. So thank you very much, and I'll turn it back to the organizers.